All right. Hi, everyone. Thanks for coming to XPC Talks. So, Sudeep Bansal is going to talk about quality measuring in primary care. And Sudeep, I'll pass it over to you. Please tell us a bit about yourself, professionally, personally, anything you want to share, and then you can jump into your presentation, and we'll do some Q&A.
All right, sure. No, thanks, Paulius. So excited to be here with a lot of smart people, and a little nervous with this, but we'll go through this. So a little bit about me. I started off as a hospitalist very early in 2009. Was lucky enough in 2010, ACA passed with meaningful use, so I kind of started working as a physician informaticist. Went on to become CMIO, implemented Epic at a mid-sized hospital. Realized while doing that the role of a CMI is actually a chief wellness officer. So kind of switched over to doing more of on the outpatient side. It was part CMI, a part chief quality officer, but the biggest things that I was doing is, how do you improve quality in outpatient practices, including designing workflows for in Epic, going to individual practices, helping them with their processes, workflows, and also a lot of contracting and negotiation with insurers around value-based contracts. So sat in the rooms with insurers trying to figure out how can we submit supplemental data to meet a lot of the value-based contracts. Incidentally, I think we were probably the first Epic instance in the country that automated CPT2 dropping with every visit, because I worked with a couple of very smart Epic people and automated the whole how to automatically drop CPT2 codes. Then after doing that for a few years, I opened my own practice in 2018. I've been running that and still working with our ACO and now, which is a independent physician organization with all the ACO contracts and quality measures. And last year, while going through all of this, I was like, I have restless brain syndrome, so I was looking for new things to do. So I started PCP Lens, being like, I've been doing quality informatics, value-based care contract negotiation and contracts for almost like 10 to 15 years. So how about if I bring all of that information in and share that information with everybody else? So that's kind of a little bit about the professional background. Personally, when I have time, I like photography, traveling if I can, and then a lot of like just having people over and grilling and having a fun time in the summer, getting all the kids together. So that's a little bit on the personal side. So with that, if everybody's okay, I can jump into a little bit of a presentation. And as Paulie said, if anybody has like questions that they want me to answer, feel free to raise your hand. If not, we can address them at the end.
Sounds
All
good.
right.
Sudeep, let's go.
All right, so let me go back to Google Slides. And of course, that disappeared. Oh, there we go. All right. Share. All right, can everybody see the slide? All right, perfect. So, so if you want to check out, I write and do my videos on pcplens.com, and also most of the videos are available on YouTube too. So the first thing, obviously, when you're talking about quality, that comes to mind is how do you define quality? And the earliest definitions come from manufacturing, and really it's along two dimensions: what does the customer want, and what is the product? So the one example is if, let's say, you have an internet provider, and if you buy the internet service but your internet keeps dropping, that's poor quality. And then the product could be that the internet provider, they want a modem manufactured that covers like 2,000 square feet of your house. And if it's not covering that 2,000 square feet, doesn't matter, that's a high quality metal, how many products go into it. But if it is not meeting the requirement of 2,000 square feet coverage for your Wi-Fi, that's a poor quality product. So that's one way to think about quality, what the customer wants and what the product is. And Phil Crosby, he took really these two dimensions and simplified the definition in saying, quality is the conformance to requirements. It's nothing more, nothing less. And Avis Donabedian, who's really the father of quality in healthcare, took that one step further and said, like, the balance of health benefits and harm is the essential core of the definition of quality. The challenge with applying manufacturing into healthcare is in manufacturing, you know who the customer is. Your customer is the buyer, and the product is being made by a manufacturer. In healthcare, this starts getting very complicated very quickly because your buyer, your customer, and your manufacturer are all different. Your customer could be your patient, your buyer could be the employer, it could be CMS, Medicare, it could be the private insurance companies. And your manufacturer could be the drug manufacturers, the device manufacturers, could be the doctor, it could be the entire health system. So we've taken this definition from manufacturing standpoint and tried to shoehorn it into healthcare. And that by itself, when you try to do it as is, you lose a lot of the nuances that come into healthcare by taking something that was defined for manufacturing. All right, so let me go to the next slide. Oops. All right. So this is what's called the Kuhneven decision-making aid. This is more sort of from an academic standpoint. The first time I learned something like this was about 10 years ago. And that's how I think about it. So that's kind of how I'm going to try to explain. Uh, Three domains, simple or the clear domain, complicated and complex. Simple domain, the best way to think about it is baking. You have a recipe, you follow the instructions, you get the results every single time. That everything is clear cut, it's laid out for you. Complicated domain is like building a rocket. There's a lot of unknowns. You know what you don't know. And you go through the rigorous, tiresome process of finding out all the unknowns, building the rocket. But it is repeatable. If you've done it once, you can do it again and again. The next one is the complex domain. Best example is raising kids. What you did for one kid may not work for the second kid. There's a lot of unknowns in complex. And then you start getting into the chaotic and the confusion. Chaotic is, there's a lot of unknowns, unknowns, and, the situation is changing very, very rapidly. So example that I give in my article was, you're working in the ICU, you have multiple people crashing, and now suddenly, let's say you lose power. And that becomes a really chaotic situation on what are you going to try to do. The domain of confusion is we have no information and you don't even know which of the other domains apply. Clinical example could be you have a new patient who's coming in, patient has dementia, family doesn't know the history, you have no idea what's going on, and but the patient is there for care. And that also happens a lot of times, especially in primary care, when you have a new patient who comes in and you have absolutely no information. So that's one way to think about the domains of decision making. A lot of healthcare that happens really falls into the complicated and complex domains. The challenge with creating quality measures is we try to take the complicated and complex domains and try to shoehorn it into the clear domain. So you do X, you're most likely going to get Y. That's one of the big challenges with quality. So even if you take like a simple example of hemoglobin A1C control in healthcare, there could be multiple reasons why somebody's diabetes is not under control. They're not on the appropriate medications, they're not taking their medications, they forget to take their medications, the medications might be too expensive, they might not have a fridge in the house to store their insulin. It can start becoming very complicated and complex. You create a simple measure that you need everybody's A1C controlled. As physicians, we have pretty much two levers. We can prescribe medications or we can fire the patient from the practice. If you put a time-bound process that every year you need to meet an A1C, it's going to be very hard if people start, they have like social determinants of health or there's other issues going on, which makes it a lot more difficult to control their A1C. So that's kind of one of the examples on how you take a complicated or complex domain and you shoehorn it into a simple or a clear domain. Let's see. So the other problem with making these complicated and complex domains into clear domains is once you make that a quality metric, you're putting financial incentives or financial penalties for providers. And that makes it a lot more challenging for doctors to kind of really respond to the situation appropriately. And a lot of us will eventually end up being like, okay, here's another medication, or this patient is non-compliant and needs to go to a different practice. Let's move on. So Donabedian tried. This is the Avis Donabedian was the one who uh, sort of came out and put this triad out on how do we, if you're trying to create a high quality healthcare system, how do we need to think about it? So the first one is structure, which is essentially infrastructure. Do you have the buildings? Do you have doctors? Do you have nurses? Do you have other ancillary staff? Do you have all the equipment? If you don't have that, you cannot provide good quality care. The second piece of this is process. Are you do you have a process for patient intake? Do you have a process that every time patient comes in, your blood pressure is being checked? Do you have a process to take care of patients? And then finally, you have the outcome. Are we getting the results that we intend to get? So the best example or the best outcome that we really should be measuring is mortality, right? That's the end goal. You want people to live longer. However, mortality can take decades to manifest. So we end up trying to measure things that are either surrogate markers for outcome or we try to measure processes. So a surrogate marker of outcome could be pain control after surgery or pain control for, if you're hospitalized. And we know what happened when we really started getting into pain control as a outcome measure. That created the opioid epidemic. I mean, I remember when I used to work as a hospitalist, Joint Commission would come in and they would review all our charts and see what the pain control is. And we would get called into the office like, hey, you didn't prescribe enough medications because your pain control was 7 or 8 and it should have been less than 3. Right? So that's one of the downsides of a outcome measure. Process, that's where we a lot of times end up defaulting because that's easier to measure. A1C is another process measure. Another example of a process measure which was a disaster, is the 4-hour pneumonia in the emergency room. So what happened in the early 2000s was for when patients were admitted to the emergency room, they were required to administer antibiotics within 4 hours for anybody suspecting of having pneumonia. How did ED physicians respond? You came in with any kind of upper respiratory symptoms, they got an antibiotic because 4 hours is not enough to determine if the patient is pneumonia. A lot of people were harmed due to antibiotic side effects from this process measure. So we kind of really have to be careful in how we are looking at quality metrics and where we are defining them. I would argue today a lot of our quality issues actually come from structure. We have large consolidated health systems, and in their quest for efficiency and saving money and increasing profits, we've really compromised on infrastructure. We don't have enough doctors, we don't have enough nurses. We're trying to save money, cut corners everywhere, and that's really causing a lot of the problems related to quality today. But what we've done in value-based care contracts is that we are trying to move all of that in processes and outcomes to try to shift the blame away from infrastructure. Uh, this is, we've always been taught in healthcare that you have to, patients need to give an informed consent. We need to tell people the pros and cons of a particular action that we are going to take, and then they need to tell us if they agree with it or not. Quality metrics really undermine informed consent. So if you start at the over here, actually, I see. So if you start, you have a new quality metric, and then you have increased pressure to meet the quality metric by doctors, leads to biased clinical decisions. Once you have a biased clinical decision because you are pressurized to meet that metric, a lot of times we will not inform people of the pros and cons. And cancer screenings are probably the biggest one where we don't people the pros and cons of cancer screenings. Uh, so you don't tell patients the pros and cons. You tell people that they need to get what is the quality metric. Your performance improves on quality metric. That becomes the new standard of care. Everybody starts following the new standard of care. And then that also decreases your medical legal liability because you're following the standard of care. Now, For doctors who want to make nuanced clinical decisions, really explain to people the pros and cons. If they decide that they don't want to undergo that treatment, that doctor's quality metric suffers. And that creates a problem and they get financially penalized. Also, when you're trying to make those nuanced clinical decisions, which goes against the grain of what everybody else is doing, that takes a lot more time during the office visit. And if the patient does decide to go against the quote unquote standard of care, that doctor is still open, they are opened up to a medical legal liability. So the challenge then becomes is right when you create a new quality metric with the understanding that these quality metrics they're designed to create new standards of care, but they also take away once you pressure doctors by giving them financial penalties. It pressures them really to actually forego the informed consent and do what the quality metric is asking them to do. And then, there's a lot of other challenges. I talked about mediocrity over excellence is, let's say for the A1C example, hemoglobin A1C, if somebody really has a lot of socioeconomic issues, uh, that might take a lot longer to resolve. And the A1C for that person might be high while you're trying to resolve the socioeconomic determinants of health. That would be considered appropriate care because if you start adding on medications, the next thing is the patient might have hypoglycemia and might have a much worse outcome. So, what you're really doing with these quality metrics is people who are poorly performing, you're trying to raise their quality, but people who are doing a really good job, in order to meet the metric, you're actually bringing them down. So, quality metrics, they create a great leveling effect in healthcare. And the challenge is we don't have randomized controlled trials to really measure at a population level when you create this leveling effect. Are we improving the health of the population as a whole? Or are we actually decreasing it? And then the last one is as soon as you start adding quality measures, you increase the complexity. And the best example of that is Charles Perrow's theory of normal accidents. And that comes out of a nuclear accident that happened, the 3 Mile Island nuclear accident, where the eventual determination was that there was a lot of multiple interacting complex elements, which kind of eventually would have led to the accident no matter what you do. And as soon as you start adding more and more processes, you start making the whole process a lot more complex. And once you start making it more and more complex, you actually it makes it a lot harder to really prevent accidents. So, paradoxically, in order to prevent accidents, you have to make the process simpler. Uh, same Going back to the example of the pneumonia quality metric, right? You The ED is a very chaotic environment. You have tons of people coming in. You have people coming in who have life-threatening pneumonia infections, and you also have people coming in for upper respiratory infections who couldn't go in to see their primary care. And we implemented the pneumonia quality metric in this really complex, fast-moving environment, and also added a time-dependent process that within 4 hours you have to make the determination if the person is pneumonia and you have to administer antibiotic. And that was led to a disaster, and the quality metric had to be withdrawn. Uh, so NCQA, I think everybody's familiar. The National Committee for Quality Assurance. They were formed in the 1990s, really to help measure quality for payers, because they wanted a way to compare quality across the board. And they created what was called the HEDIS measures with the specific criteria so that they could compare performance across different payers. But payers couldn't really control the performance of these quality metrics, so they started passing these on to the health systems down eventually to the individual doctors. These metrics, as far as I know, they work really well on a population scale, but as soon as you start kind of asking individual doctors to be accountable for them, they really you start getting into problems, and some of those which I mentioned earlier. So this is how you define what's the anatomy of a quality metric. You define a quality measure. Most of these quality measures are based off USPSTF guidelines or other society guidelines because it's easier for NCQA to take an existing guideline and make that into quality metric. Now, Just right there, you can see, you've taken the nuance out. They're called guidelines for a reason. Once you make that into a quality measure, you've made that guideline rigid. And therein, you've taken out all the nuances out of a guideline. So you have the quality measure, which is based off a guideline. You have a denominator, which is what are all the people that are going to qualify for that guideline. So, for example, for hemoglobin A1C process measure, you can argue that anybody who has diabetes and is less than the age of 85. Then you have a numerator on everybody who met the measure. So anybody whose hemoglobin A1C is less than 8, that becomes a numerator. But then you also have medicine is complex, so you have to have exclusion criteria. What do you do if somebody's in hospice? Do you really want them to count their hemoglobin A1C measure? What if somebody is undergoing surgery, or what if somebody dies, or so you start getting into all of these exclusion criteria, and so they start defining a lot of these exclusion. How do you remove these people from the denominator? And then you need to have a reporting period, and generally most of the reporting period is January 1st to December 31st for reporting periods when people are going to qualify for that denominator. And then last is the data source. What kind of data source are you going to accept? Is it going to be a lab value, discrete value? Can it be patient reported? Now with continuous glucose monitors, if it's a hemoglobin A1C, continuous glucose monitors don't report hemoglobin A1C. And I actually fell into that category for last year quality reporting when my A1C really dropped for my practice, because we use continuous glucose monitors all the time. And the payers were not set up to take the continuous glucose monitor numbers. And we weren't doing hemoglobin A1C, even though all our patients, their blood sugars were really well controlled. So that's how you kind of define a quality measure. This slide, the burden of data collection, I actually created this about 7 or 8 years ago for a technology company that we were trying to work with to collect and submit all the data to the insurance companies. So when you look at the quality data, really from an insurance point of view, they don't have a lot of the data. So from their point of view, only about a third might appear to be compliant and 2/3 might appear to be non-compliant. But when you start digging into the data, you'll find that a lot of that data is actually exists in the electronic health record or on paper. They might exist as discrete lab values. So for example, a hemoglobin A1C. We performed a hemoglobin A1C. The lab value exists in the electronic health record. But how do you report to a payer if the hemoglobin A1C is greater than 9, 8 to 9, less than 7, right? That value exists in the electronic health record. All the payer got was a bill that an A1C was done, but they don't know the value of the A1C. And how do you report that to the payer? So this becomes a reporting issue from the payer perspective. Next is, a lot of that data might exist as text values. So if, let's say, if a hemoglobin A1C was performed at a endocrinologist's office, but primary care is the one who's responsible for reporting that value. And now I have to go find the faxed note from the endocrinologist. And how do I report that to the insurance company that the patient's A1C was actually controlled and the patient is being followed by an endocrinologist? Or the data might be with a prior primary care physician. Colonoscopies, they have a 9-year look back period. Patient might have switched doctors multiple times, gone to a different state, switched insurance multiple times. How do you track down a colonoscopy report from 8 to 9 years ago and submit it to the payer to say, nope, this patient is compliant with colorectal cancer screening? So those are a lot of, on the surface, what looks as poor quality performance is really a data collection issue. And then obviously there's going to be a small number of people that that are non-compliant. So that non-compliance could be either the patient refused, the physician forgot to do it, or there were other issues which led to non-compliance. And there was an article that was published in Health Affairs, which looked at the cost of collecting and submitting all of this data in a primary care office. And they estimated per primary care physician, it's approximately $50,000 per year to collect and submit all of this data. So when everybody talks about we need to improve quality, in my head, what I think about is it's not about improving quality. It's a data collection and reporting problem. And this puts small practices at a big disadvantage. Large organizations, they have the infrastructure. They can employ a lot of data coordinators. They have all the information in a single EMR system. It's much easier for them to collect and submit this data to the insurance companies and show that they're providing much better quality of care. And this is a lot harder for a smaller practice because they just don't have the time or the tools to collect and report all of this data. And this again goes back, like, when you talk about value-based care, right? This is the problem under value-based care. You get held to all of these requirements as small practices, you just can't meet them. And so you eventually, you either go bankrupt or you sell out and you join large organizations. And then they end up going and negotiating a much higher contract with the insurance companies, and the total cost of care actually keeps increasing. So actually, this was a supplemental slide that I put in for electronic clinical data systems, but I'm actually going to stop over here. And if people have questions, we can answer questions because I think I exceeded my 20 minutes.
Oh, it's perfect. We're not that rigid. This has been great, Sudeep. So there's a quick question from Allison, whether 50K is per physician or per practice. Do you remember?
Uh, if it was per physician, if I remember correctly from the health affairs article. And
Yeah,
that's for primary care. They estimated 40,000 per provider on average, 50,000 per provider, per primary care provider.
gotcha. Yeah, we linked the article, but I don't have access, so we'll have to find a way to get access. I think it's an interesting article to look. Okay, so this has been really great. I would say we have a lot of interesting questions that people submitted when they RSVP'd, so I can kind of cherry pick some. Unless people have a question they want to ask based on what Sudeep shared, feel free to type it in the chat or raise your hand. But otherwise, um, I think if I can kick off with Eric, are you around, Eric? Let's see. Are you still here? He asked a good question. He might have jumped off. So how about Xavier? Are you still here? I know y'all might be doing stuff. Okay. Omar raised their hand. Okay. Let's rock it. Omar. And hang on, Omar. I don't think I can hear you. Nope, not yet. Unless others can hear Omar. Nope, no, yeah, I don't think so.
No.
All right. Well, Omar's working things out. Um, Xavier, if you don't mind, I think you asked a really cool question. I will refresh it. It was about um, imagine a situation in which you have an unexpected health concern, such as child experiencing concerning symptoms late at night. Do you believe contacting your primary care provider is the best way to seek support? Can you give color to this question that you
Oh,
proposed?
that's a hard one. So there's so many layers to that. Um, so the f- let's start with the assumptions first, right? The first assumption is we're assuming that every time your kid sees the same primary care provider, and they know the entire medical history and they remember the entire medical history. The second assumption is we're assuming that the same provider who sees the kid in the office is also on call, right? So we're just starting with two assumptions, and both of those assumptions might not be true. If both of those assumptions are true, then absolutely yes. Contacting your primary care provider in the middle of the night, that's probably the best bet because they already know your entire kid's history and they're probably the best person to kind of resolve the situation. But a lot of times those assumptions are not true. Uh, Today, you know, most people see multiple providers in the office, and the provider who might be on call may have no idea about the kid or may not even have access to the medical record. So it really doesn't make a lot of difference in terms of that provider answering the question or whether you take the person to the urgent care. So that's half an answer. The other part of it is if you look at it from the provider perspective, right? How do we solve for this problem? That you want to talk to the same person in the middle of the night. And from a provider perspective, that also becomes very challenging because let's take an extreme example. There is a pediatrician or a primary care physician who takes care of a lot of sick people who have high needs. If this person is on call every single day and every single night, and they're receiving 1 to 2 calls every single night, it they'll burn out a lot faster, because not only are they answering calls and taking care of issues in the middle of the night for these people, but they also have a full panel the next day. So there's a lot of assumptions and nuances. In an ideal situation, absolutely yes, you want to sort of call your provider in primary care and them take care of the issue. But in practice, it often doesn't end up being that way. The way we solve the issue in our office is we tell all our patients that, if you're open, call us in the morning. If it's, we will try to get you in the same day. We will try to have you see the same provider, and we'll try to take care of the issues. Uh, in the middle of the night, if it can wait till the morning, wait till morning. We'll try to see you. If it cannot wait, give us a call. We'll try to address it. And if it's something needs to be addressed, go to an urgent care. So I don't know if that really answered your question, but like there's a lot more sort of nuance to it.
Yeah, Xavier, feel free to add context to your question if you want.
Yeah, absolutely. No, that's sorry, I'm just thinking through everything you were outlining. It's so true that there are so many assumptions baked into the question. I guess I was thinking of it as the prompt that Holly had put was, if you could measure one thing as an outcomes measure, what would it be? And my thought behind that as an outcome measure is, if we're thinking through outcomes measures and why we set them up, I was thinking, oh, well, this is probably for some sort of value based arrangement, or for the practice to get feedback on their panel. And if the one of the biggest things that we can do is prevent unnecessary ED admissions, then people feeling like their best first point of contact is the primary care office. That's the first thing. Like, if you can only measure one thing, that's the first thing to measure. But to your point, maybe there's a better way to get around this. And I'd be curious what your thoughts would be on how do you get at that, like, that issue? Because obviously, like you said, not it's not necessarily the case that your specific physician is on call, or maybe it is the case that they need to go to the urgent care instead, or that's the appropriate thing for them to do. So how would you get at that sort of, how do we make sure that this person feels comfortable bringing themselves or their child in to see, care when they need it, rather than waiting until it advances or waiting until it becomes an emergency?
Yeah. So what you're describing is an access issue,
Hmm.
right? Uh, 15, 20 years ago, there was much better access with your own doctor. And the quality of care, I would argue, was a lot better. Today, you call for a sick visit, and either your primary care doctor or your pediatrician, it's like you have to wait 2 months out, at least in Connecticut. And that's not ideal. A lot of this has been because nobody wants to do primary care, and also now they're consolidated. Large health systems, they treat primary care as a entry point to the specialist or down for downstream surgery. So that's kind of made things a lot
Hmm.
harder. Uh, I would argue that our fee for service model is actually pretty great for providing access. Paradoxically, I'm in private practice, right? If I see a patient, I make money. I
Hmm.
have a standing this thing with my staff that if you're completely booked and a sick patient is calling and we have to stay 15 minutes later that day, we are going to stay 15 minutes later that day and we're going to see the patient. Right? You
Hmm.
take that fee for service out and you remove that incentive. Right? So we think about fee for service all the time as being really bad, but in this case, this really benefits. And I can tell you, I've talked to cardiology practices, right, that are private practice. Somebody has congestive heart failure and they need to be seen. These private practices, cardiology practices, will accommodate the patient for congestive heart failure and will save an ER admission. So paradoxically, you have fee for service that is decreasing hospital admissions. So really, the issue comes out to be access. Can you go in if you're sick? Can you see your provider the same day? And if he can solve for that, yes, it's not going to be 100% will remove all the ER admissions, but we'll actually make it a lot better. I hope that answers, or at least partially answers.
That's fascinating. Okay, let's try Omar. Do you want to try?
Yeah, can you guys hear me right now?
Yes, sir. Okay.
Perfect. All right. So, quick question I had is in regards to the cost of the data collection, specifically, who is doing it, the extraction? Is it the doctor hiring someone? Are they working with a health provider or health plan? Can you expand more about that operations and process?
This is why you don't see a lot of private practices because individual practices they don't have the infrastructure to do that. Um, a lot of practices this is one of the reasons why they sold out and went to large organizations. Then they hire data coordinators in order to collect and submit all of this data. Smaller practices my ACO does a lot of the data collection and submission. Elidate has a centralized system for collection and submission. Privia has centralized systems for collection and submission. Some of this still falls back to the doctor's office. We every few months we will get requests from insurance companies that here are the 10 patients and we need data and we have to sort of collect and submit all of that data. So you take one MA who's trained half a day out from taking care of patients and submitting that data. But the this is one of the reasons why you've seen a lot of consolidation in the industry, because individual practices they just don't have the wherewithal, so you have to centralize that.
Allison, thanks, Sudeep. Allison, do you want to share your question if you can talk?
Yes, and I'm sorry, we're on vacation, so I have children who are hanging out with me today.
That's cool.
Uh, so anyway, I am coming from this from a kind of what you just described as a practice setting that doesn't do a great job of this, but private practice, smaller, direct primary care, cash-based practices where you don't really have an incentive to adhere to any insurance rules or like larger major institutions. Like we're just assessing quality for the sake of assessing quality. In the text chat, I basically said, like, going back to your very first slides about, what does the customer want? And in this case, the patient. And then balancing the harm and benefit type of thing is kind of like, where do we go from here? How do we design good metrics?
So the question is, right, do we need metrics?
Right.
Because as soon as you start designing and measuring a quote unquote metric, then you start getting like Goodhart's law in place, right? Like people will start optimizing for the statistic itself rather than improving care. I mean, and we see that all across. You know, hemoglobin A1C, right? You're trying to optimize for hemoglobin A1C control. Hypertension, you're trying to optimize for the last blood pressure of the year to get that accurate, irrespective of what the blood pressure was throughout the year. So you start optimizing for a lot of that, and that's one of the central challenges in healthcare: is are we on the wrong train of trying to measure and force quality metrics, or should we use quality metrics more as a guiding principle rather than for system design change, rather than holding individual doctors responsible, right? If we really had to design quality metrics, I would go back to, like, we need to look at it from a systems point of view rather than an individual point of view. So if we really want to concentrate on, and actually I have an article coming out tomorrow for BMI measurement in primary care, which is probably the best example for this. We have a quality measure for BMI follow and BMI control and follow plan. Right? If we find that obesity rates are going up, is primary care really the best place that we want to address this? Or do we need to take a look at this from a national socioeconomic perspective to really put processes in place to decrease obesity rates? So I don't have a good answer to your question, but quality metrics at the individual level or even at the practice level is probably not the best way to improve quality. It has to be more at a population level, and then also to look at a system design change process rather than at a individual process, doctor's processes.
And I agree with that. It's so funny because um we in the direct primary care world often get hammered with, how do you prove quality? How do you prove quality? And I agree with you. I think the elephant in the room is that a lot of the academic literature would suggest that we can't like measure quality in primary care
Correct.
objectively. And so when I come back to people and say, actually, you just can't measure quality in primary care unless you're measuring mortality. And we know that high quality primary care equals lower mortality, morbidity, et cetera. But it's cumulative, and nobody likes that answer. Um, so I didn't know if you had better insight, considering that you kind of have to work in the system and have to come up with something. Whereas I can kind of just kick back and be like, deuces, like you guys go
Yeah.
ahead with their answer and
But
roll with
that's the to your point, right? Like that's a challenge because all of these quality metrics, they give the impression that we're doing something, we're improving quality. Oh, look, our colorectal cancer screening rates improved from like 30% to 50%, or our blood pressure control improved from this to this. So it gives the impression of improving quality when in reality it's a data collection issue. It's not really doing anything to improve quality.
Okay, well, thank you for helping me feel better about myself.
Yeah. Yeah, and this is a forever ongoing discussion. All right, so Xavier dropped the PDF of that health affairs article in the chat. Y'all can take a look. I don't know if Josh or Bryce, you want to share anything over the mic, what you've typed. Um, and then Xavier, you also mentioned the PCPCM. Like it's purely patient reported measure, if I recall, right? As like a substitute. And I've heard that some CMS programs are replacing the CAPS measure with this survey, which is supposed to be more accurate of quality, so to speak. I don't know if there's a question there, Xavier, you wanted to say, or anyone else. Also, feel free to type out things.
I mean, I guess the question would just be, so Sudeep mentioned, do we think that there needs to be a measure on this? Like if this is in the sort of complex, chaotic, or even just complicated realm, is it counterproductive to try to put a specific measure on outcomes rather than knowing that the activity is valuable and incentivizing the activity itself and sort of stripping away this administrative complexity? I mean, do we think that just asking for customer satisfaction is useful, or is it distracting? Because that's basically what PCPCM is. It's like it's a customer satisfaction survey. So like, but like asking them prompting questions to get at some of the things that are sort of more germane to what's core, not just like do they have a nice smile or something, but like is that valuable or is that distracting instead of getting at something more useful in terms of measurement?
So I don't. Are any of you familiar with Gomer blog?
Mhm.
It's uh, so Polis knows about it. So they basically it's a satirical take on what happens in healthcare. And a long time ago, they had an article about satisfaction surveys in emergency departments, and the punchline was satisfaction survey skyrockets after ED puts a bowl of Percocet in the waiting room, right? So. Uh, That's the problem with satisfaction surveys. The underlying challenge with healthcare is, unlike many other industries, is what the patient always wants is not what's always best for them. And as soon as you start denying that, your satisfaction is going to tank. And that's a very hard problem to solve in healthcare. So that's one issue. The other thing is, if you look at satisfaction surveys, right, there's a ton of bias. You will see that people always will rate higher satisfaction for a white male doctor than a female doctor, than a black doctor. And there'll be different satisfaction depending on which environment they were seen. If it's a chaotic environment beyond the control of the physician, the satisfaction goes down, versus it's a calmer environment, the satisfaction goes up. So there's a lot of like non-specific things which goes into satisfaction surveys. I mean, if you look at our we do satisfaction surveys through a company for our own practice, and the vast majority of time we get really poor satisfaction surveys are for somebody who we fired from the practice for being abusive to the staff. So yes, in an ideal world, you want to look at satisfaction surveys. If you want to look at satisfaction surveys, we shouldn't be looking at the number. we should be looking at what people are saying in the satisfaction survey. And then if you find something that is repeating again and again, then you look at that and you figure out, okay, like, yep, that's a problem. We need to work on that. And that's the model that I follow in my practice. If somebody's saying the same thing again, that, oh, your front desk staff never explains to me about this every time I come in, then, we improve that process in order to make sure that, we're doing a much better job for it. So the number itself doesn't matter. It's more what people are saying. And if that is, it's a repeating pattern, then you absolutely have to address it.
So I'll go ahead and pause the recording here for now. I think this has been